So we'll start off with introductions of everybody, and then we've got a case from Andalyn Olson today that we'll review, and then we'll have our presentation from Julia today. So I'm Troy Jorgensen. I'm the program manager for Project Echo Nevada. Manage the day-to-day operations with help from my team. Our medical director, Dr. Levy. If you could introduce yourself, please, Dr. Levy.
Hi, everybody. Good afternoon. Mordechai Levy here. Today I'll be serving mostly as the MD expert for our geriatric hub team. So looking forward to learning about driving and talking about this case.
Thanks, Dr. Levy. And Sneha? Oh, you're on mute, Sneha.
Sorry about that. I'm Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. All right, and our hub team for today, Kelly.
Hi, I'm Kelly Presser. I'm a clinical nurse leader working at the VA here in Reno, Nevada.
Thanks, Kelly. And Julia?
I'm Julia Andrica. I'm an occupational therapist working at the Continuum.
Thanks, Julia. Alrighty, so we will go out to all of you joining us today. Sneha, could you help me with introductions? I'm getting a call from Patty Swagger right now.
Sure. Georgia, can you introduce yourself, please? Georgia, do we have video for you? Sorry, audio for you?
Okay, so hello, this is Georgia Dunas. I am from UNLV School of Dental Medicine, and I've been invited by Patty Schwager to participate in this program, and I thank you so very much. And I look forward to the conversation.
Thank you, Georgia. Deborah?
Yes, Deborah Montoya here. I'm a physician assistant working both St. Mary's Urgent Cares and Carson Tahoe Urgent Cares.
Thank you so much, Deborah. Mary?
Hi, I'm Mary. I'm currently a nurse at Northern Nevada Medical Center, and I'm currently an adult gerontological acute care nurse practitioner student at UNR.
Andalyn? Andalyn, you're on mute.
Oh, sorry about that. Yeah, I'm Dr. Olson. I'm a dentist with the Nevada Department of Corrections, and I'm talking to you from Florence McClure Women's Correctional Center.
Thank you for joining us, Andalyn. Faye Neal, do we have audio for you?
Faye, doesn't look like you've joined the audio yet, so just make sure you click the little join audio icon and we'll be able to hear you. Go ahead, Sneha.
Michael?
Good afternoon. My name is Michael Redman. I'm a PA student with UNR, and I'm just listening in today.
Thanks for joining us, Michael. Sarah?
Good morning. My name is Sarah. I am from Las Vegas. I am with Dignity Health in primary care.
Thanks for joining us, Sarah. Brianne? Brianne Madsen?
Yeah, just a second here, Brianne. I'll click unmute, and then you might have to click something else on your end to unmute yourself. Go ahead.
There we go. Hi, my name is Brian. I'm a PA student. I'm also a dietitian. I'm calling from Gardnerville this afternoon, and I'm listening in as well.
Thank you, Brianne. Is that Krista?
Yep, Krista, go ahead.
Hi, I'm Krista Secord. I live in Elko, Nevada, work as a nurse practitioner here.
Thank you, Krista. Sandra?
Hi, my name's Sandra Uriarty, and I'm a guardian case manager with the Washoe County Public Guardian's Office from Reno, Nevada.
Thank you for joining, Sandra. Tracy?
Hello, I am the Washoe County Public Guardian.
Thank you, Tracy. We have somebody who's joined us through...
that was Georgia.
That was Georgia, okay.
Yep.
I think Patty just joined us.
Yep.
did. Good afternoon, everyone. Patty Swagger with the Sanford Center for Aging, and I'm part of the Geriatrics ECHO team.
Thanks, Patty. All right, so that's it for introductions today, it looks like. So thank you so much, everybody, for joining us today. As I mentioned, we're changing our practices a little bit, so please register before these sessions to help us get you into the sessions a little bit quicker. So we do have a case today from Andalyn Olson, which is great, and we've got Georgia on from UNLV to help us review that. So Andalyn, could you?
Troy, would you mind if we make some announcements first?
Oh, sure. Yeah, go ahead, Modi.
Yeah, so we wanted to, again, Mordechai Levy here, wanted to make a couple of announcements just so you kind of all are aware of, with all this kind of COVID-19 stuff going on, some extra resources that we have available. And I'll kind of hand it off to Patty to kind of finish to talk about these announcements.
Great, well, thanks. So I don't know if everyone's heard about Nevada Can. It's a website where you can go there and find some resources or plug in some information for your patients and assist them in locating some resources. So it's nevada211.org. Thanks, Moti. I see you just posted that. And so we have about 450,000 seniors throughout our state, and there was a partnership among different aging services to come together and make sure we're meeting their medical, social, and daily essential needs. And so this is not to supplant, but rather supplement other programs that might be out there. So if they need a phone call to help them stay connected, they want to participate in a group meeting, if they need food and medication delivered, or if they need some telemedicine or telehealth services. So please use that resource. Thank you.
Okay. All right. Thank you so much, Dr. Olson, for presenting your case for us, and Dr. Dunas for sharing your expertise with us today. So Dr. Olson, we'll get these recommendations kind of summarized and into a nice form, and I'll send those to you probably sometime later this week, so you can have everything formalized. All right. So we will move.
Thank you. Thank you very much.
Absolutely. Yeah, thank you. So we'll move on to our didactic for the day. Julia, I will pull up your slides, and then I've got a couple announcements in there, and then we will get going. So this is our disclaimer, just reminding you that we do record all of these sessions. If you don't want to be on video, let us know, and we can edit you out of anything that we post. Patty, do you want to talk about this a little bit?
Sorry, I was still communicating with Leslie. She's having a hard time getting in.
Looks like she's joining now. So yeah,
Awesome.
Did you cover the demographic survey?
Yes, we are receiving federal funding, and as a result of that, we asked for demographic data. So we really appreciate if you would go to that link and fill out that form. You only have to do it one time for the series, so for the ECHO Geriatric series. So if you would do that, we would greatly appreciate it. Thank you so much.
Thanks, Patty. And I'll send out that link through the chat a little later. I can't right now because I'm sharing screen. And then this is a reminder, if you do present a patient case, Dr. Olson did a great job today, not disclosing any protected health information. We want to avoid any potential HIPAA violations. So with that, Julia, I will turn it over to you.
Thank you, Troy. Again, my name is Julia Andrica, and I'm an occupational therapist. I've been doing pre-driving skills evaluations for the past 7 years at the Continuum. So we'll go to the next slide, please. No conflicts of interest that I'm aware of. And my hope is that by the end of this, you guys can take away what the key aspects are of a pre-driving skills evaluation, identify at least 2 screenings that can be done right in a primary care office to determine if a driving evaluation is needed or if that patient is safe to drive, and then to discuss the importance of executive function as it relates to driving skills. All right, so we'll go over what occupational therapy is and driving as an instrumental activity of daily living, what's included in the evaluation. We'll break down each performance skill, how to review and assess. We'll touch base on the clinical assessment of driving-related skills, do a case study, I'll provide some resources, and then we'll answer any questions. So driving as an instrumental activity of daily living, we all know is very important. The ability to get from one place to another is what enables us to participate in the things we want and need to do. In that same sense, if you take away the patient or the individual's ability to drive, you're removing essentially their independence, freedom, productivity, and control. And it also makes it really hard to get access to community, to healthcare, family, friends, and meaningful activities. So the ultimate goal is to see driving as it is very gray. It's not always black and white, and that there are options, especially by an occupational therapist, to assess, treat, and design a customized rehabilitation program if it's possible to remediate or compensate for their skill loss. So in a pre-driving skills evaluation, we take into consideration the medical history from the doctor, and then we give objective data about the main skills that go into driving. So vision and perception, cognitive abilities, motor function, the patient's driving knowledge, and then we also provide recommendations on if they should stop or continue driving, what restrictions we would recommend, and compensatory strategies or equipment if that's available. So in the medical history, obviously not a doctor, but we take into consideration all conditions, chronic and acute. And I really urge medical providers to do this as well. So for chronic conditions, it's often overlooked or maybe assumed that a patient would automatically self-restrict their driving based on how their condition could affect their skills. And that's often not the case. So vision, for example, cataracts, glaucoma, retinopathy, macular degeneration, field cuts, the list goes on. If your patient doesn't see an optometrist or an ophthalmologist annually, there might not be anybody that's catching those difficulties, and vision is the primary sense when driving. So if you're questioning your patient's ability to drive, it would be good to screen for this, or at least make sure they are working with a vision specialist. We also consider cardiovascular disease, neurological conditions, psychiatric conditions, metabolic disorders, and musculoskeletal impairments. All of this can be found in the Clinician's Guide to Assessing and Counseling the Older Driver, which is in Chapter 9. It gives you specific recommendations on what to recommend, what to restrict, when to refer. All of that can be found there. Acute consideration. So a lot of the times, the doctors that I've spoken to sometimes don't mention what the restriction should be when a patient's leaving the hospital. So seizures are more common. We know what the restrictions are, and you need to stop driving, or you may not resume driving until you've been seizure-free for 6 months to a year. But the same thing, if you've had a heart attack, a stroke, a traumatic brain injury, making sure verbalizing to the patient what the restrictions are, because they don't always know that, and they want to get right back to driving as soon as they're home. Also important to review all their medications and how those can affect driving. For me, a lot of the time people with chronic conditions are used to the medications, but that does not mean that the drowsiness, the blurred vision, dizziness, or reduced reaction time could still be negatively impacting their driving skills. So in the pre-driving skills evaluation, we assess visual acuity with the Snellen chart. It varies state by state, but in Nevada, a minimum of 20/40 is required in one eye. I know a lot of the times if someone is blind in one eye, they've been told they cannot drive, but there are so many compensatory strategies and recommendations to keep a person driving as long as they do have that minimum 20/40 vision in one eye. We do a full ocular motor screen, so looking at tracking. During the tracking exam, we'll often find difficulties crossing midline or difficulties in one quadrant versus another, which identifies maybe something neurological going on. So that's a quick thing you can do right in the office. I know in a lot of eye doctor appointments, they don't look at tracking every time. So that's concerning. We also look at visual fields. So peripheral vision, checking for any hemianopsia, especially after a stroke, any neglect, or any field cut. So we cover all of vision as it is the primary sense that you rely on while you drive. So some common visual disturbances. That first picture is how someone might be seeing with cataract. So difficulty with night vision and glare from headlights. So again, if they've had a history of cataracts removed, that's one thing. But if they have, they'll say, I have mild cataracts, but they don't need to be removed yet. It can quickly change to more severe, and this could be how they're seeing. And they could just think, I'm used to this. This is normal. But that is scary to be on the road with someone who's maybe seeing that while you're driving. Myopia or nearsightedness. Again, if they're not seeing an eye doctor and their lens prescription has changed, just important to touch base on that. Have you seen an eye doctor? Their prescription could quickly go from 20/40 to 20/60, and they're not quite sure that they need to get that looked at. Glaucoma, that third picture, it gives you tunnel vision and it eliminates your peripheral vision. So again, not something that completely restricts your ability to drive, but you would need to have that looked at, have compensatory strategies, and just be aware of how that could affect your driving. Visual perception is the next part that we assess. So how the brain is understanding and making sense of what it sees. This is the most, I would say, the most overlooked symptom. So visual perception can be broken down into the following skills on the screen. A lot of the times we see that those skills are impaired with dementia, Alzheimer's, after a stroke or a traumatic brain injury. Several neurological conditions come with difficulty with visual perception. And then in the next slide, not yet, we're going to look at visual closure. So the National Highway and Traffic Safety Administration has found that the visual closure subtest is most predictive of an at-fault crash. And surprisingly, that is the subtest that most people coming in for a driving evaluation have difficulty on, and also a skill that's not typically assessed in a primary care provider's office. So visual closure is the ability of your brain to make a whole out of parts of information. So if you're driving and a stop sign were partially covered by a tree or partially covered by snow, you might not be able to detect that that is a stop sign. That is the skill of visual closure. Questions so far on vision or perception before we jump into cognition?
Yeah, thanks, Julia. So yeah, we'll open it up right now. See if anybody has any questions. Please feel free to unmute yourselves with the little microphone icon on the Zoom toolbar, or you can write in through the chat box as well. Okay, Julia, go ahead.
Okay, so the next area we look at is cognition. So during the pre-driving skills evaluation, we do several tests to look at attention, memory, problem solving, decision making, processing speed, reaction time, and executive functions. A lot of the time, especially when we're talking about seniors, it's the fine line between normal age-related cognitive decline and then mild cognitive impairment, and then on to dementia or Alzheimer's. So really finding out where they are with their cognitive skills, because a diagnosis of dementia or Alzheimer's doesn't automatically mean that somebody can't drive. They might still have great skills in most of these areas and just need to be monitored.
Julia, there is a question that came in from Brianne. I was wondering if there's a comprehensive list of medications that impair driving for easy reference.
There is a comprehensive list. So in the clinician or the physician's guide to assessing and counseling the older driver, which I have linked for you guys, it's a little bit later in the presentation, it goes over all of the medications. And just a quick overview, it just looks at antihypertensives, anticonvulsants, all the anti-medications that could affect your vision, your attention, your reaction time. But yes, there is a specific list.
Excellent. Great question, Brianne. So yeah, that resource will be linked later in the presentation.
Okay, so my little soapbox for today, executive functions and how they affect driving. So executive functions are the higher level cognitive skills. So self-awareness, insight, and judgment, your ability to plan and make changes in the moment, abstract reasoning, impulse control. There are more, but all of those skills are super important when you're behind the wheel because you're constantly taking in new information and making decisions 1 second after the next. Executive function deficits or difficulties typically go undetected in a conversation. And that's the scary part because without executive functioning, it is hard, if even possible, to compensate for deficits in the other areas. However, if you have intact self-awareness, insight, and judgment, but maybe you have visual difficulties to one side, or maybe you're slightly slower due to age, you still are able to compensate for those difficulties. However, if you don't have that awareness, it's difficult and we can't really provide recommendations. I see a question, I think. Oh no, just kidding. Okay. So one of the, you guys may be familiar with the TRAILS B, but this is a great assessment that can be done in office to assess several areas of cognition: mental flexibility, visual spatial functioning, divided attention, and it is highly correlated with at-fault accidents and poor on-the-road testing. So this is definitely a test that we do in our evaluation. This test is also available in that clinician's guide with ability to reproduce and make copies, something that could be done right in the office. So you start the time and the patient has to connect alternating number, letter, number, letter. A lot of the times, this is one of the harder tests that we do, and people will forget. They'll go 1A, 2B, 3C, D, E, F, G. They'll forget about the numbers and vice versa. The draw a clock test is also very informative. It tells us a lot about memory, visual perception, planning and executive skills, abstract thinking, selective attention, and again, a high correlation with poor driving performance, and another assessment that could be easily done in office. Questions about cognition?
Yeah, I had a patient who said, well, you didn't tell me to draw a perfect clock when asking him to draw a clock. I mean, that was just interesting. How would I want to respond to something like that?
Well, I think it would depend on how his clock looked. So what we do grade on is the spacing of the numbers, how far or close they are to the center or the sides of the circle. So there's a difference between maybe poor handwriting and the numbers are, or even someone who's recently had a stroke and they are writing with their affected side. That's different than if you're seeing a circle that's not formed properly, or all the numbers are on one side indicating maybe a neglect, or they perseverate and draw multiple of the number 10. So I think if you said you didn't say to draw a perfect clock and it was just slightly messy, is different than if there were major flags with spacing, sizing, getting the time correct. In that test, we say usually set the hands to 10 minutes after 11. So again, that would have nothing to do with how neat their clock is, but do they do they have the reasoning and the memory and the problem solving to set those hands correctly?
Yeah, their clock looks something like what you have on your slide.
Oh, yeah. So is your question, how do you respond to that professionally, maybe?
Well, that would be part B, but anyway, that was good advice on, you know, like part A, you know, what is acceptable or not.
And that is often what people will say as they're drawing the clock. So again, this is a great test to look at executive function. So if their clock did look like that and their response is, well, you didn't say it had to be perfect, that is a perfect indication that their executive functioning is not where it needs to be. And they're not aware. And at that point, I don't discuss it with them, because that rational thinking part is, the conversation typically won't go well. They're not going to see what we're seeing.
Good question. Thanks, Dr. Dalton.
All right, so the next area that we look at is motor skills or physical coordination. So we fully assess for range of motion. You can see in the picture, cervical range of motion is very important. However, there are several compensatory strategies like added mirrors that can be used if you are limited with some areas of range of motion. We also do manual muscle testing to see that they have proper upper extremity strength and grip strength. We look at the legs and the feet. We test for sensation. A common thing that we see, especially in patients with diabetes, is that neuropathy or their inability to feel where their feet are. That's going to affect their ability to press the gas and brake pedal or to know how hard they're pressing it. And then we look at endurance. So a lot of the time, patients with any cardiovascular issues are going to have difficulty with their endurance. So making recommendations on how long they should drive, if they should be driving at all. The last part of the in-office assessment looks at driving knowledge. So we always do a road sign recognition test. We do a small driving test. It's not at all as lengthy as the one at the DMV. And then we do make sure that they're oriented to their own vehicle if that's available for us. Do they remember where the controls are? Do they remember how to adjust their mirrors? If they were to be safe to drive, we want to make sure they can actually manipulate the parts of the vehicle. So after all of that is done, we do review it with the patient. I let them know how they're doing as they go, so there are no surprises. However, I always tell them that the ultimate decision is up to the referring provider, the primary care physician, ethically and legally. But in our recommendations, we will provide compensatory strategies if they are showing that they have the cognitive, visual, and physical abilities to drive safely. We'll make compensatory recommendations if needed. A lot of the time, we're getting referrals for people with mild cognitive impairment or early stages of dementia, and we make recommendations if their executive function is intact. No driving during rush hour traffic. No driving on the highway where your divided attention really needs to be intact. If there's visual issues, maybe we'll restrict nighttime driving. But once again, your insight and awareness and ability to remember to follow those restrictions is taken into consideration. If we don't think those will be followed and then would affect safety, then we might recommend not driving. We will then review with the family, if needed, transportation alternatives. We can provide family counseling. We can recommend a behind the wheel test if they have the skills needed and we think there still needs to be, we still think that needs to be checked. And then we can offer retesting. A lot of the times with cognitive impairments, we'll recommend in 6 months to a year, they need to be retested, and we can make any referrals if needed. Okay, so the clinical assessment of driving related skills. This is found right in the clinician's guide to assessing and counseling the older driver. And I have a link on this slide that brings you directly to that. And it has all of the assessments, or several of the assessments that I've gone over today. So it will look at visual fields, visual acuity, do a rapid pace walk to look at range of motion, balance, and strength, a maze test, which really does a great job at looking at executive functions, the MOCA, which is another cognitive assessment, Trails B, and the clock drawing that we went over. So all of those assessments are free and available right in that guide. So if you are questioning your patient's ability to drive and you don't know if they need a full assessment, you can do some of these to kind of help narrow that down. So I have a case example. This is not a real person.
We have a question.
Oh yeah.
Sorry, more of a comment. Just kind of Mordechai Levy here. There's also an app for what Julia was just talking about. So yeah, you just go to the App Store and download Safe Drive is what I typed in for the AGS, and so you can get all that information on your smartphone. So I just wanted to make that one comment. Sorry, thank you.
Perfect, thank you. So this is an example of what I see a lot. This was a 72-year-old male with no acute medical events, past medical history significant for hypertension and arthritis, otherwise healthy, extensive educational and vocational history, including 2 postgraduate degrees and an MBA, recently retired director of engineering. The patient's wife and son report concerns for safety due to several close calls on the road when changing lanes and navigating intersections. Patient fully denies these events and reports he is having no difficulty. And again, I don't know if this is something you guys would typically see, and if it is, what is your current course of action?
Great, thanks, Julia. Yeah, any thoughts on this case and what you would do personally? Feel free to unmute yourselves or write it through the chat box, please.
So on the David Dalton side of things, we're out here in the middle of nowhere, so there's a chance this person's had a close call with me. And so that'll help me verify that, oh yeah, he's definitely not with it.
Yes.
But yeah, I would try to make it a light type of clinical environment just to see if I can get him to admit to or deny or further investigate that.
Okay.
Then I do the physical exam.
Thanks, Dr. Dalton. Any other thoughts on this one?
Some questions that I would, Mordechai Levy here, some questions that I kind of would be interested in is, again, just kind of to see if he would admit to it, see if you can kind of, you know, create a relationship where you can even, you know, either denies or admits what the family is saying as kind of as nice a way as possible, just to kind of see what kind of insight they have into their driving. And then just would ask some general questions about getting lost in familiar places, and looks like only close calls. So I guess that they've already answered the questions about accidents.
Can I jump in again?
Yeah, go ahead.
I think that's all great. And the reason I picked this case is because this is a perfect example of maybe early stages of a significant cognitive impairment and executive function issues where this person is not going to admit to that. Either they're not remembering or they just refuse to admit it. And in that case, you're going to have a lengthy conversation with a very well-educated person who's going to sound fully competent, fully deny any of that. However, they truly might not be safe. So that's when pulling out that Trails B assessment, doing a quick clock drawing is going to catch something that they might not tell you, because that could quickly turn into something, not just a close call. But yeah, a lot of the time with executive function issues, you're not going to detect in a conversation that that's affected yet.
Great, thank you so much, Julia. Great presentation, great information shared. So we'll open it up right now. Does anybody have any questions for Julia?
Julia, this is Kelly. I just had a question related to older adults who have dementia. We tend to see a lot of behaviors that have to do with individuals looking for their keys or wanting to go drive their car. So what is your recommendation for individuals with dementia who are no longer safe to drive? Are there any kind of diversional tactics or other safety measures or specific approaches that you can suggest to redirect them safely?
Excellent question. So I always refer people to the Alzheimer's Association, where they have classes, both in person and online, about how to divert when that conversation does come up, because you're exactly right. If they cannot rationalize with you at that point, it doesn't matter if you say, well, your doctor said you're not safe. So a lot of the time saying, you know what, we're looking into that, remember? So let me check with your doctor to try to reframe. Or in certain cases, we'll even say, hey, the car is at the shop right now getting looked at. Let me follow up with you. So just kind of redirecting their thoughts on that. But I would say family counseling is a huge piece that does get overlooked a lot, and the family members are just as stressed as the individual losing that ability. So that's when maybe getting with an occupational therapist to go over family counseling and how that looks can be really helpful.
Absolutely. Thank you.
Yeah.
A question from Brianne. How would we find an OT that does this testing, say in Gardnerville or Minden, to make the referral?
That is a great question. And if anybody knows anything that I don't, please chime in. But as of right now, I only know of myself and Renown that do the full testing. However, if you have rehabilitation clinics in your area and there is an occupational therapist there, even if they don't have specialized driving rehabilitation training, they do have training in how to assess for those areas. So, and then I would also offer telemedicine. That is now, we know more than ever, a very real option, and that might be the only option in some cases. So. Did that answer the question? I don't know if there's a specific therapist in that area.
Julia, this is Deborah.
Yes.
Yes, I'm wondering, where do you work and who do I contact? I work in the urgent cares, and sometimes one of the spouses are in for another reason, and then one of the husband or wife then tells me on the side, or even says in front of the other husband or wife, listen, this is what's been happening with the driving, and who can I refer them to besides their family provider? And because perhaps they've even tried to talk to the family provider, the husband's provider, wife's provider, and it still has not come to fruition that there is some impairment with cognition and or executive function, and they're still driving. So I work in Reno as well as Carson City, Gardnerville as well. And where do you work?
So I work at the Continuum in Reno. And I do require a physician's referral, even though Nevada is a direct access state. So patients are more than welcome to seek out occupational therapy or whatever other assessment they want without a doctor's referral. However, I personally require one so that I'm not missing any of their medical history or any other important deficits that might be present. I think you're asking if their primary care provider is, which I haven't run into this, refusing maybe to send a referral. Who would you go to?
And if some people that keep moving up here don't have a primary yet, and it can still take months.
So are you not able to refer directly?
Well, and as a question, sometimes I'll have to look into it with my national board to see if PAs are able to. If not, I can use a supervising physician as well to refer. But I was wondering who to refer them to. And OT, of course, Renown, what area of Renown does this?
Renown Rehabilitation. So
Okay.
I'm not sure if it's an occupational therapist or a physical therapist right now. It's typically an OT, but they also do this. So again, you could refer that family directly to either the Continuum or Renown or any other OT that does this. And then if you could just send the history, that would be great. It kind of bypasses that doctor's order Medicare does cover driving evaluations. That's the only insurance company that I know of that covers it, but we do have an out-of-pocket price. And they can totally bypass the doctor's referral, but it would be awesome or necessary to have the history.
Excellent. Excellent. Thank you very much.
Yes, you're welcome.
Julia, do you have a referral form that we can share with the group for the continuum?
I do not have one right here, but I can get one to Troy or Patty. Is that who I would send it to?
To Troy.
Yeah, send it to me, Julia.
Okay.
And then for those of you who would like that, you can contact me. I'll send my email out through the chat box right now. So if you want that referral form from Julia, contact me and I'll get that to you. Question from Leslie. I do want to be mindful of the time though. We're a couple minutes over. So if you do have to go, we understand. I sent out a few things through the chat box though. The first is the evaluation. So you can claim AMA Pure A Category 1, nursing, or BELTCA. So that's long-term care administrator's credit. So complete that evaluation and you'll get your credit for today's session. I also sent out the demographics survey that we asked you to complete if you haven't done so already. And then the last thing was the link to the slides. So you can download the slides for today, and that will have the links to the resource that Julia mentioned today. So question from Julia or from Leslie.
Sorry, I sent out a survey for while you guys kind of answered this last question before y'all log off, just so we can kind of get some data for our echoes. So thank you all for filling that out.
Cool. So do you do telemedicine assessments?
That's a loaded question, but yes. So up until this time, I had never done any of these assessments via telehealth, but because it is a gray area, I do feel like we can provide some sort of support or service or assessment over telehealth and at least give that patient or family further information. Yes, this was enough. No, I do need to see you in person. I can't give you a solid recommendation based on what I was able to achieve today. And I think it's a case-by-case basis, but it's definitely not out of the question.
Thanks, Julia. Any other questions before we wrap up for the day? Alrighty, I think we'll end there. So our next Geriatrics Echo Clinic is going to be coming up on May 19th, noon to 1 o'clock. I'm going to be looking at community resources through ADRC. As I mentioned, in order to get the most current Zoom link and everything like that, we recommend that you submit those sign-in forms. So the sign-in form that you can find right here on our website, and I'll send out the link to the website through the chat box right now as well. Because we may be changing the link here in the next month due to some issues that we've encountered. So thank you so much, everybody. Thank you for your participation. Thanks, everybody, for asking questions. Thank you, Dr. Olson, for presenting your case. This was a great session today. So I hope you all have a great rest of your day and a good week. Take care.
Thank you very much.